Okay, good evening, guys. Welcome to the teaching of this Wednesday, FRCS teaching from the mentor group. Sorry that last couple of weeks missed out teaching, but faculty were all very busy with various stuff. So tonight we have Kashif with us. He's the presenter. He is an upper limb surgeon from the London area. And he is gonna tell us about, present us the flexor and extensor tendon injuries from an FRCS perspective. Also with us, Shuan, as always, and also Sarfraz, who recently passed his international FRCS exam. So we welcome him, and he's very keen to help us, and that's great. After this session, there will be some hot seat Viva questions. So please, guys, anyone who's interested in taking part in the Viva, please raise the hand symbol next to your name. And it's first come, first served basis, basically. Okay, over to you, Kashif.
Good evening, guys. So basically, it's a flexor tendon injury only, not extensor, because getting both will be a bit extensive. So we'll do the flexor tendon today, and then we'll try to do rest of the hand injuries in the next session. So starting with the flexor tendons. So the word tendon is derived from the Latin word tendere, that meaning to stretch, and these tendon eludes their role as flexible cables, transmitting forces to the fingers from the common flexor origin in order to provide strength and motion at the finger and wrist joints. So a little bit about the anatomy of the flexor tendons and pulley system. So the synovial part of this, sorry, a little bit busy slide, but synovial part of the flexor sheath is segmentally thickened to form annular and cruciate pulleys. And these pulleys keep the tendon in close proximity to the bone and prevent bowstringing. So, annular pulleys are from A1 to A4, A5, and cruciate pulleys from C1 to C3. Most important pulleys are A2 and A4. A little bit about the blood supply of the tendon. So tendon has got direct and indirect nutrition. So indirect is through the diffusion from the synovial sheath, and direct through the vascular supply, which derives from four main sources. So longitudinal vessels from the palmar tributaries, vessels from the synovial reflection in the palm, vessels from the osseous tendon insertion, and those entering through the viniculi. Flexor tendon injuries are divided according to the zones. So zone 1 is the distal to the FDS insertion. Zone 2 is a FDS insertion and proximally it is up to the distal palmar crease. Zone 3 is in the palm. Zone 4 is under the carpal tunnel. Zone 5 is proximal to the carpal tunnel. And because zone 2 is the most important, although it was called no man's land, but not anymore. And thumb has divided into 3 zones, 1, 2, and 3. So whenever patient present to you with flexor tendon injuries, usually they present with the loss of active flexion, either strength or motion of the involved digit. So when you inspect those, you need to see the resting position, posture of the hand, and digital cascade, which you can see here. This is a normal digital cascade, which you need to observe. If you see any evidence of malalignment or malrotation, that may indicate underlying fracture, and you have to assess the integrity of the skin, which can help to localize the potential site of the tendon injury. Then you need to check the range of motion of the fingers with the passive wrist flexion and extension that allows you to observe the Tenodesis effect. When a wrist goes into the extension, normally digits goes into reflection at MCPJ, PIPJ, and DIPJ. If there is if Tenodesis effect is negative, that means there is a flexor tendon injury. And when you are going to check these patients, you have to check distal neurovascular status very carefully regarding digital nerves, because they are very important, and you have to check the vascularity of the digits as well, either with a digital Allen test. So treatment of the flexor tendon injuries, they are divided whether this is partial laceration to the tendon or whether it's a complete laceration. So if it is partial laceration less than 60% of the tendon width, you don't need to repair that. You need wound care and early range of motion for those type of injuries. And usually outcome is good. If there is gap formation and are triggering, then you can address later. But if a laceration is more than 60% of the tendon width, then you have to do the repair of the tendon and then followed by the controlled mobilization. In tendon injury more than 60%, outcome depends on the zone of the injury. Worst is the zone 2. So surgical technique for the approach, incision should always cross the flexion creases transversely or obliquely, never longitudinal, because that causes the contracture over the joints. Timing of the repair is very important. So usually repair is performed within 2 weeks of the injury. 2 weeks is within 2 weeks is the ideal time. As the time goes up, the outcome goes down. So there are a lot of different techniques described by different authors. It depends how you are trained. But a modified Kessler technique is the most common technique which is used, where there is core sutures you have to go, and then there is a epitendinous repair. Number of suture strengths that cross the repair site is more important than the number of grasping loops in the repair technique. Usually 4 to 6 strengths provide adequate strength for early active range of motion. And locking loops decreases the gap formation over the repair site. Ideally, suture purchase should be 10 millimeters from the cut of the from the edge of the tendon. And according to some studies, core sutures placed dorsally are strong as compared to placed volarly. And you need to make sure there should be a meticulous atraumatic tendon handling, because that minimizes your adherence. Once you have done the core sutures, then you need to go for the circumferential epitendinous repair. It improves the tendon gliding, and it also improves the strength of the repair, around 20% of the tensile strength. And it allows the less gap formation, which is the first step in the repair failure. Usually, simple running suture technique is recommended for the epitendinous suture. Then third repair is sheath repair, which is a bit controversial, but theoretically it improves the tendon nutrition through sinual pathway. Once you've done the tendon repair, then you have to do the pulley management. If there is a rupture of the pulleys, which you can find sometimes with these lacerations, try to preserve A2 and A4 pulleys in the digits and oblique pulley in the thumb, which is very important. If you have a zone 2 injury, only one slip alone is enough to repair, rather than repairing the both slips, because one slip repair improves the gliding as compared to both slips. Repair failure is a usually tendon repair is weakest between day 6 and day 12, and usually repair fails at suture knots. And gap formation is very important in the repair failure. I will come to that a little bit after a few slides. But let me finish this. So there is a little bit controversy between 75% lacerations and lacerations between 50 to 60%. If you have less than 75% laceration, some authors suggest you don't need to go for co-suture repair, just do the epitendinous repair. And if you have 50 to 60% laceration with the triggering of the finger, then you have to do again epitendinous suturing only, not the core suture. And there is a new emerging technique, especially in the hand surgery departments, to do the repair under local anesthesia in awake patient, so that you can assess the strength of your repair, and you can check is there any triggering of the fingers. So advantage of the awake repair, it allows intraoperative assessment for repair gaps by getting awake patient to actively flex the digits. It reduces the need for post-operative tenolysis by allowing intraoperative assessment of whether repair will fit through the pulleys or not. And it also allows us to on the spot debulking of the bunched repair if you have your repair is too bulky. And with this technique, you can also divide. It allows the division of the A4 pulleys and venting of the A2 pulleys if needed. And while with this technique, patient can demonstrate that inside of the sheath had been not inadvertently cut. When you are repairing that, if you cut the sheath with the tendon, that causes the adherence. And it also allows early postoperative motion. You need to immobilize these patients only for 3 days, and then you can start mid-range motion, which is half a fist, like 45, 45, 45 on all three joints. So I was talking about the formation of the gap. So studies suggest that if their gap formation is less than 3 millimeter, then outcome is good. But if a gap formation is more than 3 millimeter, according to few studies, then outcome is bad. That repair will ultimately fail if there is a gap formation of more than 3 millimeter intraoperatively, or if it is going to develop postoperatively. So this was a technique for a primary repair. If you have a patient which need a reconstruction, then there are few requirements which patient need to make for the reconstruction of the tendons. So skin should be supple, digits should be sensate, there should be adequate vascularity of the digit, and fingers should have full range of motion of the joints. There are quite few techniques for the reconstruction, but the most common technique is the Hunter technique, which is two-stage technique, where in stage 1, silicone rod is placed to create a favorable tendon bed. And then stage 2 is after 3 to 4 months, once there is a pseudo sheath formation, then you can do the tendon graft. Usually this technique, reconstruction is done by Polivitov technique, where the tendon is weaved through the flexor tendon, and then it is sutured. So for the reconstruction, graft choices are either you can use the palmus longus, although there is palmus longus absent in 15% of the cases. You can use plantaris if the longer graft is needed, and you can use the long toe extensors. Pulley reconstruction is very important, as I mentioned in one of my earlier slide. At least one pulley should be reconstructed proximal and distal to each joint. So postoperative rehabilitation, early control mobilization is very important and gives very successful results. there are quite few different protocols, but most common protocols which is used is a Duran and a Kleinet protocol. With the Duran protocol, it is a low force and low excursion protocol, and in this protocol, patient goes for active finger extension with patient assisted passive finger flexion. While in a Kleinet protocol, it's again low force and low excursion, but in this technique, patient actively extend the fingers, but there is a dynamic splint assisted passive finger flexion. So patient is in the splint with a dynamic patient is in dynamic splint. So finally, the complications of the flexor tendon repairs. So tendon adhesions are very common, and this early active mobilization protocols are very important to reduce the chances of adhesion. Re-rupture rates are 15 to 25%. So you need to warn the patient. There are always chances of re-rupture. Joint contracture is around 17%. Swan neck deformity is one of the complications. Trigger finger, if your repair is too bulky, and then your tendon may caught in the pulleys. Lumbrical plus finger, if your tension is not correct, and quadriga effect, again if your tension is not correct in the tendons. So that was all about the flexor tendon injuries. The rest of the hand injuries, probably I will go with another sessions, probably either next week or week after.
Thank you, Kashif.
If any questions, please.
Yeah, sure. I have some questions. I think you nicely covered the basic physiology of the tendons, the anatomy, nutrition, and surgical management, all very nicely, concisely in a few minutes. Which is a fair question about how does swan neck deformity develop? And I think obviously there are many mechanisms for this, but and I think you're discussing here acute ruptures, isn't it?
Yeah. So acute rupture is one of the causes.
Deformity, and I'm sure you guys understand this. It's a long-term, not an acute complication.
No, it's not. It's a long-term complication.
Yeah, so you need to make it clear to the examiner that it is a long-term complication. The deformity, I mean, it's like any question. If you're struggling in the exam to answer it, just say what you know. Describe the deformity. And as far as I would answer this, or what I know about it, is that the primary cause of swan neck deformity is the volar plate injury at the PIP joint in rheumatoid arthritis.
Yeah.
However, in flexor tendon injuries, the problem is that there will be unopposed extension at the PIP joint. Yeah. So the unopposed extension of the PIP joint on the long term causes attrition of the ligaments, which lead to the deformity. I have to revise the names of the ligaments and everything, but it's not something I deal with every day. But that's the principle. Yeah. So basically, unopposed in a tendon injury, swan neck deformity develop because of unopposed action of the extensors of the central slip, and then you can build up on that. Yeah. One more question is that the rehabilitation, you covered it very nicely, Kashif, but I think they wanted a little bit.
Yeah. So coming
more
to
about,
for the rehabilitation, because every hospital have different protocols.
Yes.
You need to know your hospital protocol. Duran and Kleinet is the most common protocol which is asked about, and there are few steps you need to know, which I have mentioned in my slides. But again, you need to know what is protocol in your hospital, because in my hospital where I have done my hand rotation, they follow the modified Norwich protocol.
Yeah.
Which is
But what they want to know, Kashif, is the principle. What's the main principle, regardless of the names?
Yeah. So the basic, okay. So the basic principle, which I have already mentioned in my slide. Let me finish this extrinsic
Yes,
and
please,
intrinsic
Kashif.
healing. Yeah. So in
Go
the
ahead.
extrinsic healing, the blood and cells needed for the tendon healing are supplied by adhesions between tendons and surrounding tissue. So that is extrinsic healing. Yeah.
Blood and cells needed for tendon healing. Yeah, okay.
Yeah. They are supplied by the adhesions. So extrinsic healing is with adhesions, while the intrinsic healing, that is with the so the intrinsic healing is that is healing, like we have intrinsic primary healing in the bone.
Yeah.
Same healing is in the tendon is intrinsic healing.
Yeah. It's like a direct and indirect in a way.
Direct and indirect repair. Yeah. Direct and indirect healing. Yeah.
And therefore, can we infer that intrinsic healing is better?
Yes. Intrinsic healing is better because you don't have much adhesions.
And that's why we repair.
If you have adhesions, that will go into this extrinsic healing.
Thank you, Kashif. Thank you for clarifying this point.
So coming back to
the rehabilitation.
Rehabilitation. So what you need to do, you need early controlled motion. So you need passive and active motion as well. So active motion will be with the extension of the fingers, and passive motion is with the flexion of the fingers. So flexion of the finger will be always passive, and extension of the finger will be active. And this is all in controlled environment with hand therapist. This need to be done under the supervision of the hand therapist.
Yeah, I mean, I think that's exactly. I mean, in principle, two schools for rehabilitation protocols in hand.
Yeah.
Active range of movements.
Yeah.
Or passive range of movements.
Yeah, absolutely. But early, because these two protocols, which are very common in the UK, Duran and Kleinert, they imply controlled motion. So there's active movements and passive movements. So active movement is with finger extension, and passive movement is with finger flexion.
Yeah, and to aid that, obviously, there will be respective blocking splints.
Yes.
Isn't it?
Blocking splint is so blocking splint is for both.
Yeah. And the blocking splint principle is to avoid overstretching of the repair tendon.
Yes. So you have to block with in certain degree of the flexion.
So, and as we are talking about flexor tendons, the blocking splint will be on the dorsal side. Yeah.
Dorsal blocking splint. Yes.
I think generally these are the principles of these, and I don't know if you need to know more, because we already spent 1 minute at least talking about it, and there's not much time to talk more. So just talk principles mainly in the exam. I think we don't need to dig.
To be honest, if you're being asked about rehabilitation protocols, you've already discussed how to repair a tendon and the blood supply.
Yes, exactly. Yeah, I think that's one of the participants asked to.
And other important thing, you need to draw what course suture technique you are going to do.
Yeah.
Most of people, they do modified Kessler. So you need to have practice on the paper how to do that.
Yeah.
Yeah, that's a very good point. Actually, you can easily get caught out. They'll say, "Draw me how you're going to do a modified Kessler."
Absolutely, yeah.
You need to know the steps inside out.
It's one of those drawings that could be asked, isn't it?
Yes.
So first of all, very important to understand that yes, it's a chronic result of a chronic injury. It doesn't happen acutely. It's something that develops over time. That's true. What's also important to understand is that it's not about one type of injury that causes a swelling. However, the principle behind it is a hyperextension forces over the PIP joint overwhelm the flexion of the PIP joint. So there are a number of causes. Number one is the primary lesion, which is usually over volar plate laxity, which means that the flexor side is not working as efficiently on the PIP as the extensor side, or a ligament, a tendon injury on the flexor side near the volar plate as well would do the same thing. That creates your hyperextension of your PIP joint. The secondary injuries are usually got to do with an imbalance between your flexor and extensors. And one of the ones that do develop is a mallet injury, where the transfer of the extension of the PIP joint is transferred, DIP joint is now transferred to the PIP joint. So the PIP joint is being forced into hyperextension while the flexors aren't as effective. Other causes are FDS rupture and intrinsic contracture, where the forces are being transferred again to cause a hyperextension injury problem. And if you get an MCP subluxation, especially volar, then that again causes hyperextension of the PIP joint, because the PIP joint now has, the extensors have a longer lever arm, therefore more force, or they're more tented as they're going out. Okay, so it's
digital arteries. They can be repaired with 9O, but you need a microscope. And again, digital nerves are repaired with a 9O non-absorbable suture. Again, you need either loops or you need a microscope. So the unit where I have worked, we have microscope, but then every surgeon, they have their own loops, which is a 2.4 magnification. Yes, because when you are exploring the finger, then you need to make sure because the sensation is very important. So you need to make sure you need to repair the digital nerve if they are injured. Finger can be viable on one digital artery. So if you have one intact digital artery, then you don't need to go for repair if you don't have expertise. If you have expertise, then yeah, that's fine. You can go for that.
Thank you, Kashif. There is another question from me.
Yeah.
Is also an exam question been asked. How do you retrieve FDP tendon if you don't find it easily presented to you when you're trying to repair it?
So how do you retrieve that?
If it has retracted, yeah.
So
especially if you go a few days or a couple of weeks after the acute rupture.
So what you can do, you can put the smallest artery forceps or mosquito inside the pulley, and you can find. If you can't find, then you have to extend the NCN. So because I have done one with my boss where we have to go into the forearm, because it was a, as you mentioned, I think it was a around 10 days or 2 weeks old injury, and patient was not in the splint, so he was keep moving the hand and fingers. So the tendon was in the forearm. So we started from zone 2, and then we gone to the forearm.
So if you're presented with a question like that in the exam, you can't find the FDP, say, my response always with a patient who is chronically injured is talk about further imaging that will help you establish where it is before you go to theatre. So,
yes, but unfortunately, imaging doesn't add much with the findings of the proximal tendon. And imaging is very much operator dependent.
And absolutely, I absolutely agree. But I'm not suggesting that this is the real life answer. What I'm suggesting, this is an exam answer showing that you are thinking about that this could be significantly retracted.
You think as safe as you can. That's the principle. You do anything you can.
Sometimes you can repair it in 2 stages. If it is a chronic injury, you can make like a tunnel. And then do the repair at a later stage. Is that something you've seen, Kashif?
No, because the 2-stage repair is for only reconstruction. If patient is coming to you within 3 weeks time, you need to prepare the patient for the extension of the incision. So you will start from wherever you're suspecting, and then if you can't find the tendon, you have to extend the incision proximally. Because the results of reconstruction or two-stage are not as good as primary repair.
Yeah.
Primary repair within 3 weeks.
If it comes after 3 weeks,
yeah, then it will be
then it will be reconstruction.
Yeah.
Thank you. I think we're starting now into level 9 questions. So
Okay.
that's good. So okay, guys. So regarding Viva, we move on to the Viva if you guys are happy. So I'll stop recording.